Then it usually takes a couple minutes for folks to join. Heather, can you see my slides if I move them? I can't. Are these moving?
Yes, I can see them moving.
Okay. And you can hear Kara and I, okay?
Yes.
Perfect. Thank you. Good afternoon, or potentially good morning if you're joining us from the West Coast. We are going to get started in just a couple minutes. We will be using the Zoom Q&A function today. So while you're waiting for us to get started, go ahead and get familiar with that Zoom toolbar. You should see a Q&A feature at the bottom. This will allow you to submit questions throughout today's presentation, and we'll be stopping to answer those questions. We really want today to be both informative and conversational, so don't feel like you have to hold your questions till the end. You can enter them in the Zoom Q&A at any point, and we'll be reviewing those. I'll repeat these instructions. I see folks are still joining, but again, thank you so much for joining us today at Leapfrog. So it's right at the top of the hour. So I'm going to go ahead and get started. Thank you so much for joining us. My name is Missy Danforth. I'm the Vice President for Healthcare Ratings here at Leapfrog. Throughout today's presentation, you'll be able to submit your questions using the Zoom Q&A feature. So take a minute right now, get familiar with that Zoom toolbar. Find the Q&A feature, and just know that throughout today's presentation, you'll be able to ask questions, and we will be answering them live. So you do not need to hold your questions till the end. Just a little bit about today's presentation. So back in 2019, Leapfrog launched the first ever annual voluntary patient safety and quality survey, specifically for ambulatory surgery centers, called the Leapfrog ASC survey. Since 2020, we've been publicly reporting on surgery center performance on a number of different patient safety and quality measures, including things like volumes of procedures, hand hygiene, and patient experience. Today, you can actually search for surgery centers and hospitals that perform same-day procedures across 9 different surgical specialties, including orthopedics and plastic and reconstructive surgery, on Leapfrog's free public website, ratings.leapfroggroup.org. Since launching the ASC survey in 2019, Leapfrog's been working hard to raise awareness among our key stakeholders, including consumers, patients and their families, employers, purchasers, and health plans, on the important role that surgery centers play in ensuring patients and their families have a choice in where they go for same-day surgery. Same-day surgeries now make up 60 to 7% of all the surgeries that are being performed. So today, I'm extremely pleased to be joined by Kara Newbury. Kara serves as the Director of Government Affairs and Regulatory Counsel for the Ambulatory Surgery Center Association, or ASCA, ASCA. And through these roles, she spearheads their federal advocacy efforts. Kara received her undergraduate and law degree from The Ohio State University and has more than 20 years of federal and state government affairs experience. Today, Kara is here joining us to talk about the Outpatient Surgery Quality and Access Act of 2023. And this is just one of the many efforts, as I've mentioned, that Leapfrog has been undertaking over the past several years to really expand the information and awareness of our key stakeholders around the important role that ASCs plays in providing healthcare for all of us. So, Kara, thank you so much today for joining us. I really appreciate you taking the time to talk to us about the Outpatient Surgery and Quality Access Act. When you first briefed some of Leapfrog's leadership team and board on this legislation at our December ASC Advisory Committee meeting, we were surprised at how much we didn't know. And you and I were actually talking about this right before I started the webinar today. That first briefing really prompted a lot of questions from us about what can be done to ensure that patients and purchasers have the quality data they need to make decisions, and that surgery centers have what they need to remain competitive on things like access, experience, and price. I'm excited about this conversation today and expect that for many of our guests, this information will be new. So I'm wondering if you can start by giving everyone just a brief overview of all the different elements that are included in the bill.
Sure, thanks, Missy. It looks like we already have a question. I don't know if you want to hold off on that, or if you want me to wait until I get to the procedure list portion. I'll briefly mention it at that point. So thanks for having me. Great to see your face again. So happy to first announce that the Outpatient Surgery Quality and Access Act of 2023 has been formally introduced in both the House and the Senate. So we can talk later about where you can find those bill numbers. I'll provide those for you, but we have actual bills. We're not just speaking in hypotheticals anymore, which is great. Very exciting for us because we're having actually our Federal Advocacy Day next week, so our fly-in for our members. So the key components of the legislation are to keep ASCs on the hospital market basket as our update factor. The default that the Secretary of the Department of Health and Human Services uses is the Consumer Price Index for all urban consumers if there has been no update factor set. But since our payment system is really the only one that CMS has oversight over that is tied to another payment system, it's tied to hospital outpatient department's payment system, we think it makes sense for us to be on the same update factor as hospital outpatient departments. In addition, we are currently the only brick and mortar facility type that is updated, that would be updated on the Consumer Price Index. So that's the first component. The second component is to have a representative on this panel that makes a lot of decisions that have, that influence the hospital outpatient department and then the ASC payment systems. And currently we don't have a representative. The quality comparison, I think, is what's most interesting and hopefully important to all of you. We want better alignment and better access to data for ASCs and hospital outpatient department quality. And then transparency regarding the payment list. So I see there's a comment here about certain codes not being on what I'm assuming you're talking about. They're not on Medicare's ASC covered procedure list. And we are constantly trying to add procedures to the ASC covered procedure list. So if you want to talk to me offline about codes that you would like to see added, I actually have a call with CMS payment policy staff later today. And one of the topics of discussion is, clearer guidance on, what CMS, what they're going to use, the criteria they're using to determine what can or cannot be payable in the ASC setting. And then the copay cap, which Missy and I have talked about, is the one I think that, we didn't really realize was a problem until this price comparison tool was established under legislation signed by, former President Barack Obama several years ago now. So what can we do about HOPD costs being so much higher than the, Missy, are you gonna do the questions?
Yes,
or,
yeah. I'm gonna let us get into this a little bit
Perfect.
deeper. As I suspected, we're gonna get a lot of questions today.
Great.
So just
Great.
let me.
I'll let you.
Yeah,
I'll let you do the chat. I'll minimize that. I'll let you do the chat box, and we can dig in. Yes.
Okay, perfect. So just to set the stage a little bit, the Outpatient Surgery Quality and Access Act today really focuses on Medicare fee-for-service patients, so those patients that have Medicare as their primary payer, and obviously Leapfrog's employers and purchasers are really focused on the privately insured. But I think what we all know, and we've certainly seen this come to fruition in the hospital side, is that what Medicare does tends to really influence what private and commercial payers do as well. And so I think, talking about this now is so timely, because depending on the fate of this bill, we could really see some of these things impacting private and commercial payment policies as well. And so
I was just going to say, Missy, I apologize. I should take a step back. You're
Yeah.
correct on most of it. The quality data, though, there is a lot of quality data that is not just fee-for-service Medicare. So we'll get into that when we talk about the quality data. So that is one component that is not just limited to looking at fee-for-service. But yes, payment policy side is mostly fee-for-service Medicare.
Perfect. So let's jump in and talk about CPIU to HMB. So for those of us that may not be familiar with these acronyms, what is the Consumer Price Index? And how does it differ from the hospital market basket?
Sure. So the Consumer Price Index for all urban consumers, which of course is quite the mouthful, tells us, what's happening in terms of the cost of consumer goods that we all use. So, you all know when gas prices are changing, which they've fluctuated, greatly over the past year or two. Milk, eggs, obviously we've got a situation with the eggs lately. So consumer goods is what drives the CPIU for the most part. And historically, that hasn't been a good indicator of increased costs to the equipment, the staffing, different costs that we find in the ASC or any other healthcare setting, really. Now, I will just preface this with, we're asking to be on the hospital market basket, which is based off of an inpatient market basket, actually. So it's not perfect for hospital outpatient departments either, but we think it's better. But right now, the hospital market basket is lower, has been lower the past couple of years than what the Consumer Price Index for all urban consumers has been. We've seen, rising inflation the past couple of years. So we still, even though technically, that would hurt us, the fact that it had been lower, we still think that long term, it's better to be aligned with the hospital outpatient departments. And we think it's better for the federal government to use the same update factor to update both ASCs and hospital outpatient departments. So yeah, this is just a quick visual of how the conversion factor has changed over the years. So under the Trump administration in 2019, they started a 5-year trial period updating ASCs based on the hospital market basket instead of the CPIU. We've seen a little bit more of a stabilizing effect with the difference between the conversion factor in the hospital outpatient department and the ASC during that time. So, like I said, we're just trying to get on using the same update factor. It's not going to, it doesn't mean that ASCs are going to get paid the same amount that hospital outpatient departments get paid, but it will hopefully, stop the growing disparity in reimbursement. That was another payment policy issue that's in our legislation, but those are, the two big things that we think will better align our payments and allow us to continue serving fee-for-service Medicare beneficiaries.
Thanks, Kara. That was really helpful and actually like a very concise explanation of what I know is actually something that's very complex. So thank you very much. We do have a question. I think it's probably the appropriate time to ask it now, okay, which is, what about those much higher HOPD costs? Is there anything in this legislation that aims to bring down some of those HOP costs and or, bring to a more of a similar point the ASC and the HOPD reimbursement fees?
So I guess my clarifying question back to you, Sharon, would be, are you saying cost or reimbursement rate? The cost, yes, obviously hospitals in general would have higher overhead and costs than ASCs, which is part of the reason that we're never advocating for, site neutral payments 100% of what hospitals are receiving. But are you saying, what can we do about the reimbursements that HOPD is receiving being so much higher? Reimbursement.
Yes,
Perfect.
my
Okay.
sense is, yeah, it's
Okay.
out of
Okay.
pocket.
Okay. So yes, and it's getting worse, and that is a big part of what we're doing with our legislation. So when ASC payments were first aligned with HOPD payments, when it became one payment rule, the OPPS ASC payment starting in 2007, and it was finally fully implemented in 2009. At that point, we were getting reimbursed about 50% for most major codes, 60% of what HOPDs were getting. And now for a lot of our higher services, it's at or below 50. And so obviously that's a huge problem. And one of the things that is being addressed in this legislation, both with this alignment of the update factor, and also there is a provision which I didn't think Missy and I we were not planning on really diving into in this presentation. It is very confusing, but the general thrust of it is that yes, that is being addressed in our legislation. There is a provision through which we're asking for CMS to look at ASC and hospital outpatient department volume collectively. Oh, is my audio breaking up?
Yes,
Can you hear me?
yes, it was just a little
might
bit.
have to- Okay. I apologize. I've had issues in the past, so I'll try and hold my mic. It might not be the best optics. Let me know if that helps. Does that help at all, or can you hear me, Missy? Okay.
Yeah.
So yes, we are trying to fix that with the weight scaler provision, and it's, I'm happy to dive into that more. But basically, some of the same issues that physicians face by the fact that CMS tries to maintain budget neutrality in individual payment silos. So for those of you who work a lot with physicians or the physician reimbursement, you may know that when some people are getting, better reimbursement, whether it's telehealth or primary care, the last couple of years during the pandemic, the surgical specialties are being negatively impacted. It's a similar issue for us. CMS is trying to maintain budget neutrality in in all of the individual payment system silos. So there's really no incentive to bring more ASC, more fee-for-service Medicare volume to the ASC setting. And so that's what we're trying to fix with the weight scaler provision. Like I said, it can get very complicated very quickly, but just know that yes, it is being discussed, and that would actually help our weights. So not directly impacting the rates, but ultimately it would probably 10 to 12%, because the weight difference is about 15%. But I'm happy to talk more offline about that with anybody who's interested. And I have probably some more materials on the weight scaler that I could share with you as well. But that huge differential between the reimbursement rates is being addressed somewhat, but as I said, we're never asking for equal payments.
Thanks so much, Kara. So we talked a little bit about the CPIU, the hospital market basket, and the provisions in this bill that are covered by there. I'd love now to jump to, I think, a topic that's been really a huge focus of Leapfrog, which is this idea of having comparable quality data between all the settings that perform the same types of procedures. So freestanding surgery centers and hospital outpatient departments. You talked at the beginning of today's presentation about these quality measures not just being limited to Medicare fee-for-service patients, but really encompassing all patients having same-day procedures. Can you talk a little bit now about what this bill will do to advance this idea of aligned measures?
Sure, and this bill in particular for right now is just asking that CMS do a better job, being transparent, sharing comparable data that across both both quality reporting programs. There are two different sites that we've referenced here. And Missy had a great idea to have me add some screen shares of what the pages look like. So we've been asking for this for, gosh, a decade now, I would say. And it doesn't at this time, you know, really force CMS's hand on developing measures that are the same between ASCs and HOPDs, but that's something that they've already been working on and talking about, and something that we consistently advocate with the agency about. So I don't think it's as necessary to put that in the legislation, because it's something that I think CMS is also interested in and has never shown that they, you know, won't work toward. We might need to, you know, more specifically ask for the same measures in the future. For instance, we have, you know, ASC 1, 2, 3, and 4, which is burn, fall, wrong events, and hospital transfers, respectively, that we're starting to collect data on again in 2023. And we would like to see at least some of those measures, burn, fall, wrong events, also added to the HOPD quality reporting program, because they're not currently. Yes, we don't. Yeah, so there are definitely differences in the measure set, and we would like to see those more closely aligned. So if you, Missy, if you want to go to the first website. So this was something that was developed even after we had been hammering hard for a long time that, you know, it was great that ASCs were collecting quality data and that, you know, it was going to become public, but, you know, that is only as useful as how accessible it is to the general public. And as you can see from this website, you know, we're used to this in the ASC community, even though there's almost 6,100 ASCs in the country. You know, there's no cute little graphic for ASCs. We're technically considered suppliers, for those of you who don't know that. But so ASCs are technically considered suppliers. But even when if you were to click on the supplier directory, it would not have ASCs listed under that either. So even though it doesn't help, but yeah, so you'd have to, in that box at the top, you know, no cute little pick to click on, you'd have to enter into the box ambulatory surgical center, and then you can see some data. I just clicked on the national so you could see the types of information that's there, but they do have it facility specific and state specific as well. So right now, really the only information is on OSPAPs, which is currently voluntary. Of course, it will be mandatory for ASCs beginning with 2025, in the 2025 year, 2024 for hospital outpatient departments, because a lot of them, they're already familiar with the CAP survey that they're doing for their inpatient operations. So right now there's not a ton of information, and it's kind of hard to work with, and not all that helpful. Once we have the data that starts to be submitted again on ASC 1 through 4, that information will also be up here in the future, just for ASCs. As we said, those measures are not in the hospital outpatient department setting. But I don't know if it was through our complaining, or, you know, that just something that CMS staff and the contractor HSAG, who they work with, and we all work with closely at ASCA, decided to put this on their qualityreportingcenter.com website. So as I was saying, it's not on the .gov. Apparently the CMS communications folks did not want to put it on the .gov website, but it is on the site that is maintained by the CMS contractor. So a lot of great information here, but as Missy and I were talking about before you all jumped on, would anyone outside of, you know, us at ASCA know about this really? I don't think it's probably been promoted to the individual ASCs that are here who participate in the quality reporting program, but I know for a fact that it's not being promoted to the general population and patients. So, you know, as you can see, there are good comparison tools that you could use here. So hopefully you all can play around with this website as well and find some valuable information. But we still think from an ASC perspective that more needs to be done, better alignment between the quality reporting programs and better access to comparative data.
Kara, I can't even tell you how I felt when you first started talking to us about this back in December. So I'm just gonna armchair quarterback this for a quick second.
Yeah, please do.
A big pet peeve of ours here at Leapfrog. So as I think a lot of our guests on today's call know, that CMS really heavily promotes their Care Compare website. It's where you can go to find information on not just hospitals, but nursing homes, and also some provider information. And CMS has really moved to this sort of star system that they're really trying to promote. And what's been frustrating to us is if you are a patient that's gotten used to going to that website, and it's being used not just by Medicare fee-for-service beneficiaries, but by a host of patients and families across the country, whether they're looking for a hospital or say a nursing home, you get used to going there to find quality information and compare facilities, and to have surgery centers, which actually outnumber hospitals, as you said, but I'm going to repeat, surgery centers that now outnumber hospitals, not show up on that website. And for you not to be able to see that information is entirely frustrating. When Leapfrog designed the ASC survey, the Leapfrog ASC survey, our first priority was making sure that when you go to ratings.leapfroggroup.org, everything about surgery centers is front and center, and those comparisons can be made side by side. I am a person who uses this explore and download Medicare provider data website quite extensively. And this isn't a place for consumers. This is a place for researchers and people like me and others who work with large data sets to download CSV files with thousands of rows and hundreds of columns. It's not made for people to look at if they're trying to make a decision if they should have a procedure done at 1 or 2 or 3 different surgery centers in their community, or 1 or 2 surgery centers and hospitals in their community. And that is really frustrating. And so I think that, this particular provision is so important. I think that the sort of starkness in the availability of information is one thing, but the ease at which patients have access to the information is really concerning. And so, yes, it's great, I guess, that Quality Reporting Center exists, but as I said, it's my job to know about these things. And until you showed me, I did not know about this website. It is not linked anywhere from the .gov site. It is not linked to from Care Compare. It doesn't actually even come up in search results if you put in ASC quality as a search term. So we are really pleased to see this in the bill. We're really pleased to see you all pushing, and it's definitely a place for alignment. So thank you so much.
Absolutely. And just one quick aside, it's not really in our legislation, but you were talking about like the star rating system. So I would just mention, in the Affordable Care Act, HHS had to do a report to Congress about establishing a value-based purchasing program for ASCs, and a very light, thin report was provided, but then no action has been taken. And when I've asked CMS, are you pursuing this? Are you advocating it? Are you working with, Congress to implement some sort of value-based purchasing program? The answer has been no. So, we're more than a decade, obviously, out from when that legislation was enacted, and there hasn't really been much movement there. And maybe that's because we still need to see more development on the quality measure side, what we're collecting, more robust information, better comparison data. So, but yeah, this website, we have a monthly call with CMS quality reporting staff and the contractors, which is great. And when they first walked us through this, we're like, that's fantastic, but nobody really knows about it. And the other thing is, because it's not on the .gov, it's not updated as frequently. So, we all just got that email recently saying that, the information at data.cms.gov was just updated. And so I went right to the Quality Reporting Center at that time to see if that had also been updated, and it has not yet. So there's going to be a lag there, but I'll ask CMS next time we talk to them when that will be updated with the most recent information.
And Kara, for someone who just asked the question, and we don't want to make the hard to find URL even harder to find, it's the second URL on this slide, correct? The qualityreportingcenter.com. That's where
that's the dashboard that you showed that's more helpful. Yes.
Yes.
Is that link?
Yeah. So qualityreportingcenter.com. So thank you so much. This, again, incredibly eye-opening. So the next element of this particular bill, which is this ASC representation on the payment panel, I think surprised us because we assumed that it's something that you had all along. So can you talk a little bit about this provision?
Sure. And this seems to be one of the easier ones. And it's actually something that, a couple of Congresses ago, we had attached, for those of you who are more familiar with how Congress works, our little Outpatient Surgery Quality and Access Act is probably not going to be signed by the president as a standalone piece of legislation, right? They're going to pick and choose provisions that they like or that they think, could move, and they're going to do that. And this is one that had moved. So we got it very close to the finish line in the past, but this is the advisory panel on hospital outpatient payments. They make determinations such as codes that should come off of the inpatient only list. They make determinations on what ambulatory payment classification or APC group individual codes should go in. So a lot of things that impact ASC, since our payment system is tied to the hospital outpatient department's payment system. However, the 17 representatives that are currently on the panel, well, there's a few polls right now, but they have to be working for a hospital or health system. And I actually just nominated someone. So we do try to get, folks who have ASC experience on the panel who work for health systems, but I had to enter the hospital CCN. So it's very specific that you have to have, hospital ties in order to be on this panel. And so we just think that one of the 17 should be designated as an ASC representative. And it also makes sense having one of 17 just percentage-wise, because ASCs represent approximately on any given year between 5 and 6% of the Medicare spend between ASCs and HOPD. So, the one out of 17 really we think makes sense for that representation. We think it's pretty easy. It doesn't cost them any money, which is usually a good thing when you're trying to get legislation through Congress. So that is a provision that we might be able to get because it's pretty straightforward.
Kara, can I ask, given that we're seeing at Leapfrog more and more hospital systems now standing up freestanding ASCs, right? So they may be joint ventures with a physician group, or even in some cases wholly owned by the hospital, but is a freestanding surgery center, it's not a hospital outpatient department. Are hospitals, systems who are investing in the development of ASCs also concerned about not having that representation on this panel? Have you talked to anyone about that?
Yeah, we could start getting into the interesting dynamic between hospitals, purchasing ASCs and wanting to have ASCs, and maybe still not wanting to lose some of their business or their volume to the ASCs, even the ones that they're in. So this has not been, it's certainly something they support. We have some larger management company and a lot of our larger companies, we have HCA as a member. They have ASCs. We've got Tenet Healthcare as a member. They now have the largest number of ASCs in the country. And yes, I think this is a pretty easy, sell for them. I don't think it's something really that the hospitals have ever really, with or without ASC ownership, have pushed back on. It's not been something that they've opposed. So I think it should be, I say this, it should be easy, but you would think it would be fairly easy to get across the finish line, to have that representation. Of course, like I said, because if they have hospital ownership, or they own hospitals, they can get, that's how we've kind of tried to get representation for the ASCs on that panel. So we actually had someone on the panel, we call it the HOP, the Advisory Panel on Hospital Outpatient Departments. We actually had someone on the panel who was our former president at ASCA, and he works for a company that owns ASCs and hospitals. And so that's how we've kind of gotten around it. But yes, it's something that I would think that definitely those who have ownership interest in both would support, but we haven't even had real pushback from the national groups that only represent hospitals. So I think it should be pretty easy to get. Like I said, nothing's ever easy with Congress necessarily, but it seems pretty straightforward.
We put the innocuous one in the middle.
Right, exactly.
The next two might be, in your opinion, a little tougher. So the next one is transparency regarding the ASC approved procedures list. And if you can give a little bit of background on that list, that would be helpful.
Sure. So, there are several thousand codes now that ASCs can perform on fee-for-service Medicare beneficiaries. And, when our payment system was first aligned, that list grew significantly, and it's continued to grow over the years, but kind of in slower fashion. So, CMS, according to the Code of Federal Regulations, is looking at certain criteria to exclude codes from the ASC covered procedure list. So it's more looking at it from, what are we looking at that would keep a code off than, CMS just adding a bunch of procedures. So it's written in the negative, I guess I would say. So what is CMS looking at? Would the procedure require active medical care and monitoring past midnight? That typically would, eliminate it from consideration, unless we have a lot of good, compelling data why it shouldn't, because we can't keep beneficiaries, we can't keep anyone. You can't keep anyone in the ASC more than a day, more than 23 hours and 59 minutes. So any procedure, so CMS looks at it, any procedure that's requiring active medical care and monitoring past midnight on a Medicare beneficiary, probably not something that should be done. And then they're looking at other exclusionary criteria, such as, would the procedure result in excessive blood loss? Does it involve, major blood vessels? So there are different criteria. Is it emergent? Is it typically emergent in nature? So those are the criteria that CMS is looking at. However, there's not ever been any set process. So there is now one that has I would say has bipartisan support, because it was something that was initially proposed under the Trump administration, although not finalized, and then it was finalized in the Biden administration's first rule. And it will provide a more transparent process. It'll provide a portal through which any interested parties, stakeholders, can, request certain codes, and they can provide, supporting information as to why those procedures should be added. So one of the big procedures that ASCA would like to see added for 2024 is total shoulder. We've had total knee and total hip on our list for total hip 1 year shorter period, but now, 4 years for knee, 3 years for hip, and shoulder is still not on there, which doesn't make any sense. I know I'm not a clinician, but I've talked to a lot of clinicians about it. It doesn't make sense to them, because even if it's a painful surgery, you're walking out, whereas, with hip and knee, probably, you know, a little less quote unquote ambulatory. But anyway, so there will be this portal through which, hopefully, it's gotten delayed now a couple years, but hopefully starting next year in 2024 for submissions for the 2025 list, you'll be able to submit these codes, and then CMS is going to have to say which of the exclusionary criteria it's using to keep it from going on the ASC cover procedure list. So they would have, if we formally request total shoulder, for instance, they would have to say why they're not adding it. So, of course, the more information, the more outcomes data, the more information that we can provide as an ASC community will be helpful for them in, you know, guiding their decision making. And there's not a ton of specific research on a lot of the procedures. So I know we were talking about some of the procedures somebody was asking about earlier. You know, if there are specific codes that you would like to see added, happy to try that. I will say, if it's something that's not considered a surgical code, if it's ancillary to a surgery being performed, you know, it has to be done in conjunction with a primary code. So I know that there are some things that are done, you know, independently in a hospital outpatient department that can be done because hospital outpatient departments have a much wider scope in terms of what they can do. They're not just limited to surgery or surgical codes. So it does have to be either a surgical code or something done in conjunction with the surgery, but I'm happy to talk, like I said, offline with anybody who has procedures that they would like to see added. But anyway, yeah, CMS is going to have to show their work. What we've done historically, and I have a call with CMS payment policy staff this afternoon still actually, is we submit codes for consideration. And sometimes we've done presentations to CMS medical officers, and often they stare blankly at you and don't give you any indication as to whether or not they're going to add the procedures. Sometimes they do, sometimes they don't, but there was never any you know, requirement that they give us the rationale for exclusion. And, you know, under this new nominations process, they will have to do that. I will say we still kept it in our legislation because CMS can always change its mind. And, you know, we saw the final Trump rule added almost 300 new codes to or actually it ended up being like, I think 255 procedures to the ASC cover procedure list, or 258, that's right. And then the first year of the Biden administration, they took 255 of those back off of the list. So, you know, since it's something that can be changed relatively quickly and easily, depending on administration, we would like it to be codified in statute, and we think that it would be a lot harder to change, obviously. And so that's why we've kept it in legislation.
Thank you, Kara. That's really helpful. I want to just pick up a little bit on one of the comments you made earlier when you were describing this, which is this sort of process of, you know, submitting additional codes representing additional procedures for consideration and presenting outcomes data to sort of support, you know, it's safe to do this thing in this particular setting. What has been the importance of having that outcomes data, and what's the importance of having more outcomes data in the future for this particular element and for moving more procedures onto this list in general?
Yeah, I mean, I think that, and we all know this with, you know, private payers too, they want that outcomes data as well, right? So it's not just a CMS thing. And of course, the current head of Medicare, so basically, you know, second in command at CMS is Dr. Amina Seshmani, who is an ENT by background, and we met with her in late 2021, and she was very, you know, direct about the need for outcomes data. Of course, one of the difficult things for us is that it's hard to get ASC outcomes data for Medicare beneficiaries if there's no reimbursement rate for the code to be performed. However, we have had some, Medicare Advantage plans who would allow codes. That's how we had some data for knee and hip on Medicare, age population prior to being added to the ASC covered procedure list for fee-for-service Medicare. And then interestingly enough, although there were not a lot of ASCs who participated in the Hospital Without Walls program, just over 100, we have had some who were able to perform codes, off of that were not on the ASC covered procedure list when they were operating as hospitals. So we do have some outcomes data for total shoulder and some spine procedures that's Medicare age, population, which is great. And I think that'll be, critical to our efforts moving forward. What we try to do is, find data for those close to the Medicare age. That's helpful, but to your basic question, yes, I don't think we're going to move the needle. I don't think we're going to get procedures added unless we can show some data to CMS.
That's really helpful, Kara. We've been trying to sort of understand where those outcomes measures opportunities are. As you know, we've talked about CMS has taken the approach for ASCs to look at unplanned hospital visits or ER visits following surgery done in a surgery center for certain surgical specialties like orthopedics, urology, general surgery, and that certainly gives some information. But I think from a patient perspective and certainly from Leapfrog, while we greatly value those measures and definitely see a place for them, getting to the complications level, not just that return to hospital or return to visit, because there is some granularity in the severity of complications. I think is something that's really important to the folks that we talk to. Based on where kind of insider baseball, the types of outcomes data that ASCs can produce, to inform lists like this. Do you think we're close to getting more granular on certain types of complications, or do you think that's still really far away?
I mean, I can tell you that the management companies have fairly sophisticated information. I just saw a really incredible dashboard that one has, and I'm like, oh my gosh, I didn't even know that you had this. Let's put in this specific code and 12 different metrics come down or whatever, all their ASCs that perform that procedure. You can see, where they act on all, where they were on all those. It was fantastic. I think all ASCs are collecting outcomes data, whether it's all in the same format or they're using the same definition has been, one of our issues. I think, you've talked with Kathy Wilson with the ASC quality collaboration. There's a lot of interest in having a more expansive, SSI measure, surgical site infection measure, and there's still a lot of discussion about that definition and what it would look like in the ASC setting. But people are collecting that information. They're collecting information about how the especially with we were talking about total joints, it just might be different intervals. So it's like some people might go back to the patient 3 months out or 6 months out. Some are even taking that to going a year out. And so trying to see if we can get everybody collecting the same information, and that would be helpful. But I'm sure we could talk about this all day, and we could probably have more conversations about that. But yes, I think it's important to streamline that information and make sure everybody is on the same page in terms of what's important for different procedures and what information we should be collecting and sharing, whether it's with private or public payers.
Thanks, Kara. That's really helpful and I think really encouraging. So thank you so much for that. And so the last piece that we're going to talk about today, I think, is one that you've said even some surgery centers don't know about, and that's this copay cap. So what is the copay cap? and then let's talk, and then we'll show an example of sort of the real life implication of it, but maybe some background first.
So, and I will just say, I have worked with ASCA since 2011, and I was not aware of the issue until this lookup tool went live in 2018. So it's not just our members who are unaware, it's, it was us. And basically we were all excited when this lookup tool was mandated back in 2016, under the 21st Century Cures Act. We thought it would be a great tool for Medicare beneficiaries to use. It would be a great marketing tool for our facilities. Show, beneficiaries how much they were going to pay to have their procedure done in an ASC and an HOPD. So you can go to the first one if you want, Missy. And I will say it doesn't look quite as different as it used to, because CMS did not used to have the physician fee included on this page. They added that in the last year or so. And since the physician fee is the same for both ASCs and HOPDs, it makes it look like the difference isn't as great between the beneficiary's responsibility. But anyway, you can see that the facility fee for the hospital outpatient department is approximately twice what it is in the ASC. And as such, the 20% patient responsibility is, higher. As I said, the doctor fee is the same for both, so that kind of throws it off a little bit. But for our code by volume, by far, 66984, Medicare beneficiary is going to pay less. No, you're good. We can move on. The Medicare beneficiary is going to pay significantly less for having their procedure done in the ASC. However, we started looking at the information for some other procedures, and I use this one as an example because it's one of the more gaping disparity. I guess it's a lot higher for ASCs than HOPDs. Although the little graph, CMS doesn't do a great job of making the graph look bigger, but you can see that the patient responsibility in the ASC for this spinal code is, more than twice as much. And we're like, what the heck is going on here? And it turns out that approximately 20 years ago, CMS added a cap on what the hospital outpatient department would receive from the Medicare beneficiary. And the whole point of it was great. It was a good thing because it was supposed to better align, the fact that there was an inpatient cap with outpatient. So it was to encourage, the appropriate volume to shift to the outpatient setting. So the cap currently is $1,500 for a procedure. However, there's no such cap in the ASC. So for a lot of these codes, and it's increasing in number as, reimbursement rates obviously increase, but also we have higher complexity cases and, like total joints and things that are being done in the ASC setting, Medicare beneficiaries are going to pay more. And it's really an access issue, and it's only impacting really those who don't have supplemental insurance. And, the data shows that really the beneficiaries and our minority beneficiaries, predominantly Black beneficiaries, are less likely to have supplemental insurance than white beneficiaries. And so that is, like I said, it's an access issue overall, but also really impacting, all of our Medicare beneficiaries who don't have that supplemental insurance. And so we're trying to get a similar cap to what the hospital outpatient departments, and the hospitals are made whole. The Medicare program makes the hospitals whole for the difference. So you can see here that, the hospital outpatient department's only getting $1,728 from Medicare beneficiary. However, they're getting, that little bar on the side that shows what the ASC is getting. They're getting that difference from the Medicare program. So in some ways, it's kind of like a double whammy for taxpayers, the Medicare program, in terms of we're paying a higher amount because the base rate is higher in the hospital outpatient department. So you're taking that access away from the lower cost setting. And in the end, the hospital's being made whole anyway by the Medicare program, so they're paying that amount, which would have typically not been paid, like I said, under the ASC. So this would be a cost to the Medicare program, but we think ultimately that it would result in savings. So we've done some modeling and show that even a slight 2% shift in volume for the procedures that currently run afoul of this payment policy, the copay cap, there's about 150 codes that do. Even just a 2% shift in Medicare volume to the ASC would result in savings, additional savings to the Medicare program, and of course provide greater access to both facility types for Medicare beneficiary.
Thank you so much, Kara. This was really surprising to us because it seemed like such a basic patient protection that you would have this in place. And it seemed like unless you were a patient who was trying to do this kind of research, you may not even understand what's going on here. I mean, so many of us don't understand the insurance that we have, right? And even if we work in healthcare. And so this is such a complex thing that really leaves, to your point, some vulnerable patients even more vulnerable. Do you see this being more of an uphill battle because it's not budget neutral? Can you talk a little bit about that?
Yeah, it certainly can be. We made a big push toward the end of last year as different packages were being floated to try to convince Congress that ultimately it will be a saver. It is a difficult one because the way that the budget office, the Congressional Budget Office, evaluates potential costs or savings, they don't do dynamic scoring. So they don't look at that potential future savings that we were just discussing. They're just looking at, we would be paying more for procedures we're already, not paying more for. But, we think that's very short-sighted, right? Because we're just not seeing a lot of volume being done on these procedures because of the fact that the beneficiary is going to have to pay more. And to your point, beneficiaries don't know. We had a lot of doctors. We have a lot of doctors who didn't know. I was telling you, we had one potential patient come for a procedure, and they said, well, I want to have it done in the hospital outpatient department because I won't pay as much. And so, we need to make sure, and that's why we try to educate our members on it so that they know, because obviously that negatively impacts patient satisfaction. And, we don't want beneficiaries to have to pay more to have their procedure done in the ASC. But it's very short-sighted because it's costing everyone in the long run, access to our facility and more money. So it is more of an uphill battle. We also do, though, have more support for it, I think, from other, specialty groups, from device manufacturers. We've got bipartisan support. Our legislation, which I'll just give the bill numbers really quickly, HR 972 and Senate Bill 312. So HR 972 and Senate Bill 312. In the House, it's Congressman Brad Wenstrup from here in Ohio. I live in Ohio, but from here in Ohio, he's a physician. John Larson, the Democrat from Connecticut. Richard Blumenthal in the Senate, Democrat from Connecticut. And Bill Cassidy, also a physician, Republican from Louisiana. So it's bicameral, bipartisan legislation, always has been. And as we add more co-sponsors, we really are cognizant of trying to keep it fairly balanced, Republicans and Democrats who co-sponsor, so that we have a lot of support for it moving forward. So hopefully we can get some of these things through, even if they would cost money on their face. So yes, it is a coster on its face, but we're still relatively optimistic because it has a lot of support and it is a patient issue and a patient access issue. We think that helps move the needle.
Kara, that's actually like a perfect segue. We only have about 2 minutes left, but for those of us who are on today, whether we're hearing about this for the first time or thought we knew about it, but learned some additional detail, what are the different ways that individuals and organizations can support this as it moves its way through Congress?
Absolutely. Even if there's just key provisions of it that you're really supportive of, and you have contacts with your local members of Congress, or even if you don't, we're happy to put you in touch with those. As I mentioned, we're, if there's any ASC on the line, we're doing a big push, like a letter writing campaign for people to write to their members of Congress, but we can certainly send that link to others as well. We have our day next week, or our fly-in, where we're going to be talking about the issue on the Hill. But we typically talk about, a couple of different things when we go meet with members of Congress. So even if you just have an extra minute or two and you say, hey, there's also this outpatient, Surgery Quality and Access Act out there, I think you should really take a look at it. There's great provisions, better alignment of quality metrics, access to care. That's helpful. We have a lot of resources on our website that I'm happy to share with anyone. But yeah, there's plenty of ways you can get involved if you would really like to, and feel free to reach out to me with any questions.
Thanks, Karen. I just realized I forgot to put the last slide up, which had your contact information. So I'm putting that up right now. So we had some questions about whether or not we can distribute these slides. And I see Karen nodding yes. So we will get this out to you. We'll get out the official names of the bills so you can search for those. We'll get the links that Karen is referencing if you want to give support. I personally, Carrie, just want to thank you so much for your time today. We took the full hour, and I think it was a really—
I didn't think we would.
Oh, I knew we would. I think it was a really important conversation. I think that, as Leapfrog is really learning so much about the important role that surgery centers play in caring for patients, we want to spread the word among others. This was an important conversation to help advance that. And so I really appreciate your time today. I'm really looking forward to sharing this information with our key constituents. So the slides, your contact information, links for follow-on. So thank you so much.
Great. Thank you. Thanks, everybody. And please do feel free to email me.
Yes, I'll distribute your email address with the slides, the recording, and the other information.
Okay.
All right.
Thanks, Missy.
That's your day. Thank you, everyone, for joining us. Bye-bye.